Welcome to Healthcare Rewired, the podcast that explores actionable lessons and insights for improving healthcare from digital health's leading innovators and champions. I'm your host, Mark Noble, and I'm thrilled to be discussing how to solve the access to specialty care challenge for rural communities today with Zach D'Argonne, President and CEO of Eastern Plains Health Collaborative in Colorado. Zach, welcome to the show.
Hey, Mark, thanks for having me. It's a pleasure to be here.
We appreciate you coming on. Zach, not everyone is familiar with rural health networks in our audience today. So if you could take a moment to share with us what the role is of the rural health network and why they're so critical to the sustainability of the independent hospitals in rural America, that'd be great.
Sure. Happy to do it. You hear the phrase a lot. If you've seen one rural hospital, you've seen one rural hospital. That phrase certainly applies to if you've seen one rural health network, you've seen one rural health network. So what a rural health network is really it in its most basic form. It's an opportunity for hospitals to create scale that they don't necessarily have at the individual level. So we got started 11 years ago on the Eastern Plains of Colorado, really with that vision in mind of how do we take these 15 independent rural frontier critical access hospitals and create scale to align our voice instead of 15 small hospitals kind of shouting into the void. If we could consolidate that strength into a network of hospitals from a policy and advocacy standpoint, from a shared services standpoint, from a provider recruitment and retention standpoint, education, leadership development, all of our hospitals individually will be stronger together, which is a tagline you hear quite a bit with these rural health networks. So our specific vision and mission is to strengthen the financial sustainability of our independent hospitals in a world where, over the last decade or so, we continue to see rural hospitals close. The philosophy is if we can try and act like a system without the downside or the obligation of a system partnership, we will help sustain our hospitals in a meaningful way. So that's what we look like. Again, there's nuance throughout the country, but at the end of the day, these rural health networks are here, and you're going to see some important growth and development in a more official capacity in the years coming, because we're starting to get a lot more attention from Federal Office of Rural Health Policy, NRHA, so on and so forth, saying, golly, given everything coming down the pike with HR1 and the tenuous payer landscape, these independent hospitals really need a level of support above and beyond, their own consolidated board of directors. So that's the role we try and fulfill.
Yeah, and we're seeing that in the rural health transformation programs too across the country, where
Yes, sir.
there is a lot of focus and emphasis for exactly the reasons that you brought forth here in the role that the rural health networks play, is that on their own, the future is bleak for rural independent hospitals, but through collaborative efforts, there is definitely opportunity for strength. Uh, uh,
And
one of
Mark, just one more thread to pull on that you brought up. A question we get a lot from the city slickers, right, is, well, why doesn't what's the risk, right? Why, if your hospital starts circling the drain, won't some healthcare system scoop you up? Won't the academic medical center pick you up? And the reality is the critical access financial environment from a business or strategic perspective from a large healthcare system, it isn't an appealing one, right? If some business development leader at the academic medical center said, hey, I think we should go acquire any of these hospitals on the Eastern Plains of Colorado, they'd probably lose their job pretty quickly, simply because it's hard to run a profitable critical access hospital, and it's only getting more difficult. So the safety net, so to speak, of, hey, some system's going to come in and save the hospital and therein save the community is a false assumption in many cases.
Yeah, yeah, and I think there's an important implication of what you just said too, in terms of save the community. What we've seen is that when the community hospital closes, it has significant, not only, healthcare access impacts for that community, but financial impacts because they're frequently the largest employers in the community as well, right?
That's absolutely right. Yeah, it's time and time again, it's it's either the hospital or the school more often than not is the largest employer, and there's a reason the United States Department of Agriculture is one of the most uh, invested, literally from a financial standpoint, federal departments in rural hospitals, because the USDA understands if the hospital closes, pretty darn quickly, the community is going to close and agriculture is going to suffer as a result. So it's the timeline and the speed to which communities can really shutter, which has a negative impact on our food, on our gas, on our oil, energy, so on and so forth, is profound.
One of the challenges that we see time and time again for these rural communities, even when they have a critical access hospital, is that they still have an access gap when it comes to specialty services. To put some numbers around that, for rural America, on average, it's a 67-day wait time to see a psychiatrist. 86% of rural communities in the US don't have a cardiologist within the community to be able to go see. And all this amounts to an average wait time, if you will, or travel distance of 40 miles to go see one of these specialists, which contributes to 1 in 3 members of these rural communities delaying treatment for situations that really should be attended to immediately because of the cost and because of the distance with travel and that sort of thing. So hearing that, someone not familiar with the plight of rural health may be thinking to themselves, Zach, why don't they just go out and hire these specialists? How would you respond to somebody who thought that way?
I wish it were that simple. I guess would be my immediate response. Yeah, Mark, and it's a problem, and it's going to continue to be a problem in a big bad way. And I think what a lot of people miss is, to your point, the 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 geographical burden of trying to get into a city like Denver, or whatever the metropolitan area is so burdensome that individuals will just forego healthcare, preventative healthcare, wellness healthcare, and then by the time they're walking into our hospital, they might not be walking into our clinic, they might be walking into our emergency department,
Right.
which is another reason why we don't want to see these hospitals close. But um, no, it's a significant challenge, and we're doing things to mitigate it, and we have our plans. So I don't want this entire interview today to be, woe is me. But since you asked the question, the the challenges in recruiting these individuals is multifactorial, right? We know from a population dynamics standpoint, if we look at our 16 counties that we cover, 15 out of those 16 population metrics are predicting a deterioration of population over the next 5 years. So rural communities populations are not growing, and the population group that is growing is typically the 65 plus individuals, which is it's useful, right? Because guess who utilizes healthcare? Individuals who are over the age of 65. Um, but the amount of, we're all familiar with the maternity desert. The amount of babies being born into these communities is deteriorating, and as a result, kind of deteriorating our pool in which we can recruit from. It's really common. EPHC and other networks and rural hospitals are engaging young, talented individuals as early as middle school to try and communicate with them and develop an interest in healthcare, so that one day, hopefully, they eventually come back to the rural community to help solve that problem. The headaches for why we really have a hard time simply going out and hiring individuals is a few things above and beyond the geography concept I just outlined. It's a volume issue, right? We have to specialty providers cost money. The costs of healthcare have done nothing but skyrocket in the last 6 years in a post-COVID world, and we continue to expect expenses to go up in a frontier environment where we have less than one person per 6 square miles. If I'm going to go out and spend, upwards of, nearly $1 million to recruit a cardiologist full time, I sure as heck need to make sure that the back of the napkin math works and that I have the population dynamics to keep Dr. Mark busy so that I can generate a profit in order
Right.
to sustain that service line. And more often than not, in a vacuum, when we look at those numbers, it simply doesn't work. So that's an issue number one of, do we actually have the volume to cover our high fixed expenses, and we're adding variable expenses to that to be able to cover, uh, from the business perspective, to sustain that provider. Number
Right.
two, it can be a challenge recruiting to some of these places, right? When we look at the Eastern Plains of Colorado, um, not everybody wants to work in a rural frontier environment where you take housing, for example, on the Eastern Plains. There is affordable housing. It is possible to find a house that is affordable, but not necessarily one that is up to par with a specialty provider that wants to move him, his spouse, her spouse to a rural community. So when you're in a recruitment phase and they're walking down the street and there's not a lot of housing available, and the housing that is available isn't clean and shiny, the type of house you envision yourself purchasing when you go to medical school, that's a
Right.
barrier. And oftentimes, when we do recruit an individual to a rural community, it's as increasingly important that we connect with their spouse as it is with them, because usually it's the spouse that says, I can't do this anymore. You look at the western slope of Colorado and it's the inverse problem, right? Everybody would love to go move to the western slope, the Vale, the Glenwood Springs, the Aspens, um, but you can't afford housing to live there in the first place. So housing is a really good example of a barrier that we run into. So those are the quick challenges that come to mind as to why it's not as simple as people might think. You take a look at obstetrics. Colorado is 54% of our counties have obstetric services. So about half of the state do not have obstetric services because it's a very difficult service line to generate revenue for. It's not, labor and delivery services are not reimbursable on the Medicare cost report. It's an extraordinarily high expense service line. And you talk about vital importance for women's health and childcare in these communities. It's simply impossible where our hospitals are having to make a decision. Okay, do I invest in women's care and obstetrics care, or do I keep my ER open? Because that's a lot of the decisions that our hospitals are having to make. And if you want to be a critical access hospital, you have to have an emergency department open.
Yep. Got it. So that certainly paints the picture. So if you don't have access to the specialists locally and such, what are these critical access hospitals doing? What's the alternative? How do they end up solving for these care gaps?
Yeah. Um, there's a few different ways, right? We're obviously on a virtual and telehealth podcast here today, right? So that's the low hanging fruit answer. But the reality is as low hanging fruit as that feels in a vacuum, it's easy to say and it's hard to do, right? We certainly have our telehealth partnerships, and we continue to pursue telehealth partnerships um, in a meaningful way. What telehealth allows us to do from a specialty care perspective is to aggregate our volume in a meaningful way, right? One
Right.
individual hospital on the Eastern Plains of Colorado is not going to have the volume to recruit, even from a telehealth standpoint, a rheumatologist, because a telehealth organization or even a large healthcare system is going to say, uh, from a volume standpoint, it doesn't make sense for us to recruit an additional rheumatologist or dermatologist uh, to bring into the state of Colorado, because one hospital is not going to be able to sustain the revenue generation we need from a professional services standpoint to do that, even if we want to partner with your hospital. But all of a sudden, if we can have 5, 6, 7 hospitals say, yes, we will cover the cost of this rheumatologist, whether from an employment and a reverse lease agreement with those hospitals, or partnering with a telehealth vendor or a healthcare system, that back of the napkin math all of a sudden works, where 7 hospitals can take on some risk to say, we're confident enough, we will have the volume to cover 1/7 of this provider. and the partner is going to feel more comfortable with 7 hospitals really targeting appropriate growth in those settings. So that's one example from an outpatient telehealth perspective. Of what we are doing in a clinic setting to really try and aggregate our resources and align our processes so that folks don't have to go into the large city. We certainly have partnerships within our hospitals for traveling specialists to cover certain amounts of days throughout the month, right? Whether that's from a surgical standpoint, we have traveling orthopods, general surgery. We have traveling obstetrics where, yeah, we might not be there full time, but whether it's from with a third party vendor or organization that fulfills some of these staffing solutions, or if it's with a larger healthcare system that's looking to develop a partnership with a hospital and establish in a community, we have general surgeons coming in and doing surgery on or clinic and surgery on Monday, rounding on Tuesday, and then driving or flying back to the city so that we can bring some of those services to our hospital, which is hugely important for our facilities, right? Number one, first and foremost, patients are receiving care, to your point, Mark, that otherwise might not be receiving care, period. Number two, it helps our hospitals generate revenue that otherwise we would not be getting. Those specialty services, it's not just the patient encounter in a vacuum, it's the imaging that we receive from that. It's the laboratory revenue that we generate. If there's a procedure, great. So the kind of the unit cost basis of just one more, every single patient that we add really helps give us a little bit of breathing room above and beyond our fixed costs, so to speak, because in a critical access environment, Mark, our fixed cost is somewhere between 90 to 93%. So adding one more patient, adding one more procedure, adding one more image, one more scan, one more laboratory, our variable expense is pennies relative to the revenue. So we really try and partner with those organizations, with larger healthcare systems to generate those incremental patients, because that's what's going to help make or break our hospital from a volume perspective. It's
That
it's
that
not about growing the population. It's how we keep more patients at home than we did the previous quarter.
Yeah, exactly right. And the interesting good thing about that is not only is it a better care for the patient, but based upon what you were just saying, it is a financial sustainability aspect for the
Yes,
hospital
sir.
to have that patient retention, right? So if they did have to, somebody showed up with a cardiac issue, if they did have to send them out to tertiary hospital, it's 40 plus miles away, uh, they lose all the downstream revenue from that, don't they?
Right. Yeah,
Yeah,
that's absolutely right. And it's the existential risk for us, right? I think what's really missed and the difference between a critical access setting is we're community hospitals, right? We are positioned. The front door of our hospital is not the emergency room. The front door of our hospital needs to be the outpatient clinic setting, and we need to be proactive, engaging that patient population in a meaningful way. Because for every specialty that we don't have, right? If I'm a critical access CEO and I have to ship Mark to Colorado Springs for his cardiac appointments, guess what? The likelihood that Mark comes back to my hospital for other specialists that I do have, for primary care that I do have, that risk increases, right? Because you've created a relationship with another organization, whether they're predatory or not, is
right.
is frankly irrelevant. The risk exists because every time that you're not getting your care at my hospital, it's much harder for me to get you back into the four walls of that building.
Got it.
Yeah.
So basically what I heard there is there's really two options that you've got in terms of getting the specialty expertise that you need into the community. It's partnerships with the tertiaries where they are physically sending people on site to provide those services, or you're accessing those services with the providers remotely via telehealth. And the key to making that financially feasible and sustainable for these critical access hospitals is through aggregation of volumes and such, because otherwise it's not, uh, feasible and sustainable. So that leads to this concept of shared services. And Zach, for other rural health network administrators and such that may be listening today, or even those who are thinking about starting a network, can you give them kind of a roadmap or how you go about thinking about generating a shared services, offering, and how you get buy-in from the membership and all that? So what does that process look like?
And that's where the network can come in, right? It's a good example of how you can create scale to bring value to the members of a rural health network. So when we think about shared services, we're trying to hit three buckets, right? Bucket number one, we're trying to create savings for our hospitals for a service that our hospitals need that they're paying for. But if 15 hospitals, if EPHC can negotiate on behalf of 15 hospitals, are we going to create a discount so that we lower their expenses? Bucket number two we like to pursue is there an opportunity for us to, on the other side of that coin, generate revenue for hospitals, which is where a clinic service can certainly come in. And then number three, from a sustainability standpoint for the rural health network, a nice to have but not a need to have is, um, our with that endorsement and with that partnership is the third party company that we partner with able to provide any sort of financial support for the rural health network so that we don't have to push costs down to our members and raise their membership fees. So we've been really effective at doing it, and it's an important part of a rural health network. um, some of the things we've done, we partner with an organization called Elevate IT Health, who really has helped take our organization from crawling to running quickly. There are our IT staffing and system solutions. So more than half of our hospitals are receiving discounts for the technology services they provide, the cybersecurity services they provide, the development of the IT leaders throughout the Eastern Plains. They run our IT education and affinity group. They help aggregate the staffing. So if your IT leader 45 miles away wants to go on vacation, guess what? You actually get to go on vacation. They help us aggregate our USAC applications for approval. So it's a good example of helping drive down some costs for our hospitals. They EPHC has, in essence, some version of a commission agreement with them, and we're retaining the talent and the staff with an aligned set of technology, with an aligned set of processes and protocols across our hospitals, so that we're really stronger together from the cybersecurity standpoint. We partner with a swing bed optimization company that comes in and assesses our swing bed programs to make sure that we are retaining and keeping every patient that we can. And when we do have to transfer a patient to a larger level, a higher level of care, they're the dog with the bone, proactively chasing that patient on behalf of our case management departments to make sure that Zach or Mark is transferred back to the rehabilitation swing bed program in our rural community and not admitted upstairs at the level one or level two trauma center. We partner with provider recruitment organizations, organizations that help us from a board governance development standpoint. We partner with Ovation for their health trust GPO from a purchasing and supply chain perspective. And maybe some of the most important work that we're doing is working on underpayment recovery and pricing transparency data. So these organizations that can help our hospitals track, from a private payer accountability standpoint, track what our negotiated rate is, understand if we have an underpayment, and they help us go chase those dollars to make sure that we're improving the bottom line of our hospital. So that was fast and furious, but those are just some ideas of what we have. I'm always, not a month goes by where I'm not connecting some other network leader to one of these organizations or talking through how we do things. Like I said, it's if you've seen one rural network, you've seen one rural network. And I think the really cool part about our little cohort, there's about 35 quote unquote networks in the country. We all share, and there's no competition among us. It's a true growth mindset, abundance mindset, sharing mindset. We all have to work together, just like we encourage our member hospitals to work together. We at the network level have had to adopt that as well, and we beg, borrow, and steal best practices from throughout the entire country to try and strengthen our hospitals.
And that's great. That's one of the things that I have enjoyed in working in rural health for as long as I have, is the It is a truly collaborative environment where folks roll up their sleeves and anybody is willing to share something that was successful or not successful with the rest of the group to help them avoid making the same mistakes. Zach, I know that you got to run. I can hear you bleeping, but I want to thank you for joining us on the show here today and sharing your insights and experience. And for our listening audience, thanks for tuning in. Join me, Mark Noble, next time here on Healthcare Rewired for more insightful episodes focused on proving healthcare through digital health. Thank you, Zach.